to everyone. This is your Professor Dr. Cabrera. I'll be discussing today a topic in pharmacology 2, which are drugs used in gastrointestinal disorders. GI tract serves as many functions that provide numerous important drug targets. Now, this lecture will discuss drugs which are commonly used in GI disorders. For definition, what is a peptic ulcer? A peptic ulcer is a lesion in the lining of either the stomach or the duodenum. If the peptic ulcer is located in the stomach, you call it your gastric ulcer. If it's ever be located in the duodenum, it is called your duodenal ulcer. Okay. Your Zollinger-Ellison syndrome, or ZAS, is a syndrome with a triad of gastric acid hypersecretion, severe peptic ulceration, and a non-beta cell islet tumor of the pancreas, or a gastrinoma. In this condition, there's an increased levels of the hormone gastrin, which causes the stomach to produce excess amounts of hydrochloric acid. With such condition, it can lead to peptic ulcer disease in almost 95% of patients. So what are the drugs used in acid peptic disease? Okay. As you all know, ulceration and erosions of the GI lining are common problems. And here are the drugs that are included for the management of your acid peptic disease. These are classified into antacids and rafting agents, your gastric anti-secretory drugs, your mucosal protective agents, and your antibiotics. Your gastric anti-secretory drugs are your H2 blockers, antimuscarinic agents, your proton pump inhibitors, and your octreotide. Your mucosal protectives are your sulfate, your colloidal bismuth, your carbenoxolone, and your prostaglandins. And now let's talk about the antacids. So what are antacids? These are simple physical agents that react with the protons in the lumen of the cat, thereby neutralizing the acid. So some antacid will be aluminum containing, and this may stimulate the protective functions of the gastric mucosa. When antacids are used regularly, it reduces recurrence rate. So when you use it, it is used to raise the stomach pH to an alkaline level. So antacids will differ in absorption and effect on stool consistency, especially those magnesium and aluminum containing, which are the most popular. So these two are non-absorbable weak bases, especially your magnesium is a strong laxative, while your aluminum is a constipating agent. They can be available as a single ingredient or a combination. Your calcium carbonate and sodium bicarbonate are also antacids, but these are absorbable weak bases. They are less popular because of their systemic effects. Remember, your sodium bicarbonate is the one that the sodium can affect, your water retention and blood pressure, and your bicarbonate increasing the pH of the blood, so as with your calcium. So what are rafting agents? So rafting agents are the agents that react with the acids to form a gel which floats in the stomach and prevents acid in the stomach from flowing to the esophagus, otherwise in a condition called your reflux disease. Using rafting agents will relieve symptoms of reflux like heartburn and protects the inflamed esophagus and which later on will encourage healing. A very good example of your rafting agent will be your sodium alginate. Okay. So let us now proceed to the agents that are anti-secretory. These are the gastric anti-secretory drugs, namely your H2 blockers, antimuscarinic drugs, and your proton pump inhibitors, and your octreotides. So, what are octreotides? These are this is used to treat severe watery diarrhea and the sudden reddening of the face and neck caused by certain types of tumor, especially those who are of carcinoid tumors and your vasoactive intestinal peptide tumors that are usually found in the intestine and in the pancreas. So your octreotipeptides are octapeptides that mimics natural somatostatin pharmacologically, though it is a more potent inhibitor of growth hormone, glucagon, and insulin than the natural hormone. So, what are H2 blockers? Okay, we have several classifications. So your H2 blockers, you have for available ones in the market. You have your cimetidine, your ranitidine, your famotidine, and your nizatidine. These are all equally effective drugs, and with the H2 blockers, the cimetidine is the prototype. Since they are H2 blockers, they do not structurally resemble those who are H1 blockers. They are very active when taken orally with a short half-life of 1 to 3 hours. They are relatively non-toxic, so they can be given in large doses just to extend the duration of action of one dose. In large doses, it can reach to 12 to 24 hours. So your H2 blockers act to produce a surmountable pharmacologic blockage of your H2 or histamine 2 receptors. So it blocks, is an antagonist. Okay, so and it is relatively selective, and the use of your H2 blockers will not have a significant effect on your H1 or even on your autonomic receptors. The only therapeutic effect of clinical importance is the reduction of gastric acid for your H2 blockers. So the blockage of your cardiovascular H2 mediated effects can be demonstrated but not clinically significant. So we use your H2 blockers in the management of your acid peptic disease, especially those of the duodenal ulcer type. It will reduce the symptoms and accelerate healing and prevent recurrence. For acute ulcers, you might give more than 2 doses per day. For recurrence, it can be prevented by an additional of 1 bedtime dose. So for gastric peptic ulcers, the use of H2 blockers can accelerate healing and prevent recurrence. Okay, so this is a table differentiating the different H2 blockers with their dose and capacity to prevent recurrence. So we have 4 drugs. Okay, you have your cimetidine, your ranitidine and nizatidine are equal, then your famotidine. So your cimetidine, it is given at 400 to 600 milligrams twice a day or at 800 milligrams at night. Your ranitidine or nizatidine is given 150 milligrams twice a day or a 300 milligrams single dose at night. Or famotidine, you can give it at 20 milligrams twice a day or a single 40 milligram dose at night. Okay, so recurrence, so all of these can prevent recurrence. Half of the active ulcers can have bedtime dose. Okay. So In cases of your Zollinger-Ellison syndrome, we use large doses of your H2 blockers to control symptoms like your acid hypersecretion, your severe recurrent peptic ulceration, GI bleeding, and diarrhea. But with the use of your H2 blockers is not as effective as your proton pump inhibitor, Omeprazole. Regarding for the use of in your gasto-esophageal and reflux disease, you can also use your H2 block, but still in comparison to your proton pump is still more effective. For toxicity, um, the drug will be inhibited by metabolizing enzymes, and this drug may reduce hepatic blood flow. So if there's slow hepatic blood flow, there will be slow metabolism of warfarin, theophylline, diazepam. Okay, and comparing cimetidine to your other H2 blockers, your cimetidine has more toxic reactions comparing that to your ranitidine. Your anti-androgen effects in many patients, it is manifested with the use of cimetidine only. Headache can be produced with the use of ranitidine and your famotidine. And among your H2 blockers, they can be reversible hematologic abnormalities. So regarding the combination therapy, so because it is expensive, so we do not recommend it much. But in cases of refractory disease, which occurs in 20% of cases, you might need higher doses, prolonged course, and you can switch to other H2 blockers. Even you can try switching to cytoprotective agents, or you can try combining it with antibiotics. Now after your H2 blockers, we now go to your muscarinic antagonist. So your muscarinic antagonist acts by competitive inhibition of the muscarinic receptors. And your muscarinic antagonist can cause some reduction in gastric acid secretion and GI relaxation. So these are your muscarinic antagonists, your atropine, your methylscopolamine, and your propantheline, okay, are previously used in peptic disease to reduce acid secretion. But they found out that it is not as effective as your H2 blockers, and they carry more adverse effects. Now, for your proton pump inhibitors, the as example would be your Omeprazole. So the pump is the H-hydrogen potassium ATPase, which are found in the luminal membrane of the gastric parietal cells. So your Omeprazoles irreversibly binds with the pump, and this binding will result to the inhibition of acid secretion. So there will be no hydrogen ion, so to produce your stomach acid, that will be your hydrochloric acid. If you inhibit the production of hydrogen or secretion of hydrogen to your gastroparietal cells through the irreversible binding of the pump to omeprazole, so you will inhibit now the formation of your hydrochloric acid, and this secretion can be prevented for a period of more than equal to 48 hours. Thus, it is very useful in conditions like your Zollinger-Ellison syndrome and in your gasto-esophageal reflux, for which comparing with your H2 block, so your omeprazole or your proton pump inhibitor has is able to be more effective. So your octreotide are long-acting synthetic somatostatin analog, and it acts by significantly inhibiting the secretion of several circulating peptide hormones. Thus, it will inhibit gastric and pancreatic secretions. Octreotide is used in cases of your Zollinger-Ellison syndrome with some reported improvement. The downside of using octreotide or its limitation is it is limited only for intravenous or parenteral use. Now we go to your mucosal protective. Your mucosal protective have for your sucrose, your colloidal bismuth compounds, and your carbenoxolone, and your prostaglandin, your misoprostol. So can you still remember what in your OB/GYN, what is the use of your misoprostol? So it enhances cervical ripening and thus induces abortion if used in for such indication. Okay, so your sucrose are made up of aluminum sucrose sulfate, and this is a small polar poorly soluble molecule. So what does it do? It polymerizes in the acid environment of the stomach, and when the polymer binds to the injured tissue, forming a protective coat over the ulcer bed, so it protects. Okay, it's a mucosal protector. Thus, it accelerates healing of your ulcers and reduces recurrence rate. So, since it is too insoluble, there's no problem with systemic absorption. So, there's no systemic effect. Your colloidal bismuth, on the other hand, selectively binds on an ulcer, then coats it and protects it from acid pepsin. And there are studies that show that it may have some antimicrobial action against your Haemophilus pylori, Helicobacter pylori. And with the use of ulcers, it promotes ulcer healing by 98% when it is combined with antibiotics like your metronidazole and your tetracycline. So limitation of use is its cost and possible toxicity. Okay. Your carbenoxolone is the synthetic derivative of your glycyrrhizic acid, which is an agent extracted from licorice. Okay. This is shown to be effective against gastric and duodenal ulcers. Okay. And it induces the increased production and secretion and viscosity of the intestinal mucus or carbenoxolone. Now let's go to antibiotics. Okay. So the use of antibiotics is warranted if there's a case of chronic infection with your H. pylori. So these chronic infections can be seen among patients with recurrent peptic ulcer disease. So what we do to prevent this recurrence is to eradicate the cause, your H. pylori. So if you eradicate your H. pylori, you greatly will reduce the recurrence rate. So with the use of antibiotics, the choice are in combination with Omeprazole. So you can use Omeprazole plus bismuth, tetracycline, and metro, or amoxicillin and clarithrol. Now we proceed to the drugs that promote upper GI motility. So the loss of upper GI motility usually occurs in cases of diabetes and other diseases that damages the nerves to the viscera, causing frequently marked loss of motility of the esophagus and the stomach, thereby resulting to delayed emptying, nausea, and severe bloating. So there are two drugs that are studied for the promotion of upper GI motility. That would be your metoclopramide, which is an antiemetic agent, and your cisaplin. So these are both useful for the loss of pathogen motility. So what does it do? It stimulates motility probably by acting as an acetylcholine facilitator or as a dopamine receptor antagonist. So these are the proposed action. They serve as acetylcholine facilitator or a dopamine receptor antagonist. So with their prokinetic activity, it also helps prevent emesis, especially in cases of surgical anesthesia and emesis induced by cancer chemotherapy, okay, which is commonly seen or managed by metoclopramide. Okay, for the adverse effect of the drugs, so the use of both drugs can induce Parkinson-like symptoms and other extramental effects. And nowadays, we cannot see cisapride in the market because it has been withdrawn due to the, I think it's more of a cardiovascular adverse effect. Now, aside from metoclopramide and your cisapride, we can also use the effect of erythromycin because erythromycin has a prokinetic activity in the stomach as a motilin agonist. So it is very effective among diabetic, gastroparestic, and intestinal pseudo-obstruction. Okay. So for prevention and treatment of vomiting among cancer patients, you can also use your metoclopramide and cisapride. You can also use your dexamethasone, some H1 blockers, several phenothiazines, and your 5-HT3 inhibitors like your ondansetron and your granisetron, okay, and your dronabinol, which is an active ingredient of marijuana. Okay, so what is granisetron? Granisetron prevents nausea and vomiting caused by certain cancer drugs, especially that is used for your chemotherapy. Okay, how does it work? It works by blocking one of the body's natural substances, like your serotonin, that can cause vomiting. Sure, granisetron. Okay, for pancreatic enzyme replacements, in conditions wherein there is an inadequate pancreatic secretion of lipase, it will result in a condition called your steatorrhea, which there will be, it's a result of a decreased fat absorption coupled with a lot of fat in the stools. Okay, and this steatorrhea could be significantly relieved by oral pancreatic lipase, or otherwise called your pancrelipase, which are extracted from pigs. This pancreatic lipase is inactivated by a very acidic pH if the pH is less than 4. It leads to 90% destruction of your pancrelipase unless you increase the stomach or make it more basic by the use of your antacid or your acid reducers. Now, going to the pancreatic lipase replacement, now we proceed to your laxatives. This is so those who are having frequent constipation, you listen up, okay? So your laxatives are used to increase the probability of bowel movement by several mechanisms. So we have at least 2 mechanisms involved. First is the irritant action on the bowel wall, and second is the bulk forming action on the stools, which will later on will evoke the reflex bowel contraction. So examples of irritants will be your castor oil, your cascara, your senna, and your phenolphthalein. Bulk formers are your saline cathartics, okay? That is your magnesium hydroxides and your psyllium. Okay? So that's the medications for your constipation. Now we proceed to the drugs used for your irritable bowel syndrome or your IBS. So your IBS is defined as chronic relapsing disorder that causes abdominal discomfort and alterations in bowel habits. So treatment are directed at relieving the pain and discomfort and improving bowel functions. For IBS, can have several variations. There could be IBS. There could be IBS that can be predominantly having loose stools or diarrhea, and those IBS predominantly are constipated. So for those who have predominantly diarrhea, we use anti-diarrheic agents like your antimotility drugs like your loperamide. And for those who are constipated, we can use fiber supplements. But the problem with fiber supplements is that it may aggravate gas production and bloating. For your osmotic laxatives, especially milk of magnesia, okay, are used to soften the stools and increase stool frequency. For chronic abdominal pain, okay, with IBS, so pain and the manifestation. For chronic abdominal pain, you can use low dose of tricyclic antidepressants. So low dose, like your amitriptyline and your desipramine, at 10 to 50 milligrams per day. Since this is low dose, it doesn't affect the mood, but may alter the central processing of your visceral afferent information. The anticholinergic activity of your tricyclic antidepressants may also decrease GI motility and secretion. Altering the receptors for enteric neurotransmitters like your serotonin will affect visceral afferent sensation. Now for your antispasmodics, okay, your anticholinergics for your irritable bowel syndrome. So some agents are promoted to relieve abdominal pain through antispasmodic actions. Though spasms does not seem to be an important cause of symptoms in your irritable bowel syndrome, you can use your dicyclomine and your hyoscyamine, okay? And these drugs will inhibit muscarinic cholinergic receptors in the enteric plexus and on the smooth muscles. So there will be efficacy for relief of abdominal symptoms in IBS, okay? These are not demonstrated, okay? Rather, they may exhibit significant additional anticholinergic effect at higher doses. Thus, they are infrequently used. Now we go to your serotonin 5-HT3 receptor antagonist. Your 5-HT3 receptor antagonist in the GIT will activate your visceral afferent pain sensation via the extrinsic sensory neurons from the gut to the spinal cord and the CNS. So the inhibition, okay, will produce reduction in the unpleasant visceral afferent sensation, including nausea, bloating, and pain. Blocking it will reduce central response to visceral afferent stimulation, and blocking it at the terminals of the enteric cholinergic neurons will inhibit colonic motility, thus increasing total colonic transit time. So it increases motility. Okay. Your allosetron is approved for treatment in women with severe diarrhea with predominant IBS. However, the efficacy of this drug in men is yet to be proven, so it's not proven. The dose is 1 milligram once a day or twice a day. It reduces pain and discomfort in a study wherein it reduces pain and discomfort in 50 to 60% of cases. comparing that to the placebo, which only decreased around 30 to 40% in the mean number of bowel movements per day. There are associated but rare serious GI toxicity like constipation up to 30% of patients, serious complications of around 1 in 1,000. The occurrence or the risk for ischemic colitis is 3 in 1,000. So the use of aldosterone is restricted to women who have not yet responded to conventional therapy. And the drug didn't show any significant interaction with other drugs. So there, aside from that one, we still have 4 others. Okay, your ondansetron, your granisetron, your dolasetron, and your palonosetron, which are been approved for the prevention and treatment of nausea and vomiting, but still their efficacy in the treatment of IBS is yet to be determined. Now, from the irritable bowel syndrome, now we go to the inflammatory bowel disease, which comprises 2 conditions, your ulcerative colitis and your Crohn's disease. Okay, your ulcerative colitis is an inflammation and ulcers in the colon only. That's why colitis. Okay, inflammation and ulcers in the colon. While your Crohn's disease is inflammation that may affect any part of the GI, not only the colon. Okay. However, with these 2 conditions, the etiology and the pathogenesis is still unknown. So the pharmacologic treatment is that the drugs that belong to different therapeutic classes have different non-specific mechanisms or anti-inflammatory action. So we choose drugs on the basis of disease severity, responsiveness, and the consideration of drug toxicity. Okay. So here is a therapeutic pyramid approach with your inflammatory bowel disease. So the lowest part that deals with bowel disease, the lowest, least effective, but least toxic, okay, will be the use of your sulfasalazine and your 5-aminosalicylates and your antibiotics. Next to that will be the use of your steroids, either your corticosteroids or your budesonide. Going up, there's the use of your immunomodulators like your azathioprine, your 6-MP, and your methotrexate. Farther up again is your biologic agent, and the topmost will be your surgery. So topmost is where your severe diseases will be managed. Okay? So the treatment of choice is predicted on both severity of the illness and responsiveness to therapy. So those agents, if we can remember, those agents at the bottom of the pyramid are less efficacious, but can carry a lower risk of serious adverse events. Okay. Drugs may be used alone or in combinations. Patients with mild disease may be treated with your 5-aminosalicylates, especially with your ulcerative colitis or Crohn's colitis. You can use also topical corticosteroids, your ulcerative colitis, your antibiotics for your Crohn's colitis or Crohn's perianal disease, or your budesonide for Crohn's ileitis. Okay. Patients with moderate disease or patients who fail initial therapy for mild disease may be treated with oral corticosteroid to promote disease remission. Immunomodulation, like your azathioprine, mercaptopurine, your methotrexate, that will produce or maintain disease remission, or the use of your anti-tissue necrosis factor antibodies. Patients with moderate disease who failed other therapies or patients with severe disease may require intravenous corticosteroids, anti-TNF antibodies, or even end up in surgery. Well, your natalizumab is reserved for patients with severe Crohn's disease who have failed immunomodulations and tissue necrosis factor antagonists. Your cyclosporine is used primarily for patients with severe ulcerative colitis when they have failed a course of intravenous corticosteroids and tissue necrosis factor. So you can do further reading about these other drugs for your IBD. Okay, Now we'll move on to the treatment of gallstone using bile acid therapy. Your ursodeol or your ursodeoxycholic acid is a naturally occurring bile acid that makes up around 5% of circulating bile salt pool. It is taken per oram or per mouth. It is absorbed, conjugated in the liver with lysine and taurine, and excreted in the bile. The half-life for this one is quite long. It's 100 hours. So it can be used for long-term daily administration, wherein 30 to 40% of your circulating bile pool. Okay. Mode of action, it reduces cholesterol content of the bile by reducing hepatic cholesterol secretion. Thus, it can promote stone dissolution. So, okay. It is used for dissolving small cholesterol gallstone in patients with symptomatic gallbladder diseases who refuse or are poor candidates for cholecystectomy. The dose is around 10 mg per kilo per day for 12 to 24 months. In such length of time, they have observed that can resolve 50% of non-calcified stones, especially those measuring less than 5 to even 10 millimeters or 1 centimeter. There's no known adverse effects, okay, but there are some reported cases of bile acid-induced diarrhea. Now, what are the drugs used to treat variceal hemorrhage? So, portal hypertension usually will occur secondary to a chronic liver disease, which this chronic liver disease can manifest as ascites, hepatic encephalopathy, gastric and esophageal varices, which may rupture and cause hemorrhage. So there are several drugs to reduce portal pressures to prevent rupture and hemorrhage. So this used in short term for the treatment of active variceal hemorrhage, or even used long term to reduce the risk of hemorrhage. So what are the drugs? So you can use your somatostatin and your octreotide. Okay. Your intravenous somatostatin at 250 micrograms per hour, or your octreotide at 50 micrograms per hour for 3 to 5 days reduces portal blood flow and variceal pressures. So though the mode of action is poorly understood, but they have found that it helps by inhibiting the release of glucagon and other gut peptides that can alter mesenteric blood flow. So your somatostatin and your octreotide can be effective in promoting initial hemostasis from bleeding esophageal varices. Now you can also use your vasopressin and your terlipressins. Okay, your vasopressin is an antidiuretic hormone. It's also a potent arterial vasoconstrictor. So it's given intravenously by continuous infusion, and it can produce arterial constriction that reduces splanchnic pressures and lowers portal venous pressures. However, because of its action, it is not commonly used now because of safety concerns. Because if you give a vasoconstrictor, arterial vasoconstrictor, it can induce hypertension, myocardial ischemia in those at risk, or even infarction or mesenteric infarction. However, if you really have to use this, you have to use it with co-administration of your nitroglycerin, which may also further reduce the portal pressures. Okay, your terlipressin is a vasopressin analog that appears to have similar efficacy to vasopressin with fewer side effects. However, it is not available in our country and in the US, but in some other countries, maybe in India or otherwise, they can be available. Now, we discuss now the use of your beta receptor blocking drugs. So your beta receptor can reduce portal venous pressures while decreasing your portal venous inflow. Secondary to the decrease of cardiac output, a function of your beta-1 receptor, and your splanchnic vasoconstriction, the stimulation of your beta-2 receptor. the blocking, okay, action. Okay, so the use of this drug is associated with 10% reduction in incidence of bleeding in patients with no history of varicella hemorrhage. Non-selective beta blockers significantly reduce the rate of recurrent bleeding, although a reduction in mortality is still not seen. And that's it. God bless you all. I've done discussing your motility drugs or drugs used in gastrointestinal disorders, but still you have to read the book, okay, and hope that you pass my exams. And of course, don't forget to subscribe to my channel, think your thumbs up, subscribe, and turn on your notification for future lectures that it may serve you in your study. So thank you. Salamat po.